Hey, it's Steve Kronlage. I'm here to talk to you about carpal tunnel syndrome today and how we treat it. So, what do nerves actually do? They're a conduit to carry information both to and from the brain. Think of them as electrical cables carrying information. There are two types of peripheral nerves. There are sensory nerves that carry sensory information, which is touch and temperature, and there's motor, which carries information to muscles to make them work. Most common nerves are mixed, both sensory and motor. Nerves conduct information via an electrical impulse, which is an excitable membrane with sodium-potassium pump. The Schwann cells are basically the insulation that's around the nerve. The more insulated the nerve, the faster and the more stable the conduction. Blood supply to peripheral nerves is important. There is two types. There's the axial, which is along the nerve, and then there's segmental, which are vessels that feed the nerve. Compression causes a breakdown in one or both areas. The smallest non-insulated fibers are the ones that are injured first with compression. There's a dose-response relationship to the duration of compression and injury. There is a breakdown of the blood-nerve barrier first, and then there's edema and fibrosis that occurs, and then demyelination occurs. Then following demyelination, which is basically loss of the insulation around the nerve, you get Wallerian degeneration, which is basically death of the nerve. The carpal tunnel is the terminal portion of the median nerve. The median nerve originates from the lateral and medial cord of the brachial plexus, which are nerve roots C5 and 6 and C8 and T1 respectively. It innervates the volar arm muscles, the median nerve does, and it gives rise to the anterior osseous nerve in the forearm. This is the only nerve that passes through the carpal tunnel. It gives sensory innervation to the three fingers and the thumb, as well as strength to the thenar muscles, which are the thumb muscles. Most hand muscles, other than the thumb muscles, are innervated by the ulnar nerve. What are symptoms of carpal tunnel? The most common symptom of carpal tunnel is nocturnal numbness and tingling in the median nerve distribution. That will be the thumb, index, long, and ring finger. As it progresses, daytime numbness can occur and weakness, and constant tingling can also be present. You can have proximal radiation or numbness. With chronic cases, atrophy can occur of the thenar muscles. Carpal tunnel syndrome, compression of the median nerve, is a result of anatomy. The transverse carpal ligament is palmar, which basically is the roof of the carpal tunnel. The carpal bones are dorsal. It is a closed space. Anything that did not used to be in the carpal tunnel, but is now, can lead to symptoms. Synovitis, which is swelling of the tendons, thickening of the tendons as occurs with age, thickening of the ligament, which occurs with age, and arthritis. Very commonly, arthritis of the thumb is noted to cause carpal tunnel syndrome. A little bit about wrist flexion and extension in carpal tunnel syndrome. Carpal tunnel pressures were measured in patients when they were in neutral, and that's around 2 to 10 millimeters. But with wrist extension, there's a tenfold increase in wrist pressure in the carpal tunnel. There's a 20% increase in pressure with that in wrist flexion. So pathologic conditions around the carpal tunnel like synovitis, less compliance of soft tissue due to age or diabetes, and arthritis will all increase the likelihood of clinically significant compression, and which would be made worse with wrist flexion. So initially, we tell patients to sleep with splints. That will keep their wrist in neutral while they're sleeping, and they can get some relief from that. So who gets carpal tunnel? Well, it's 90% of all compression neuropathies, so it's a pretty common problem. It's in 4 to 5% of the general population at one time. The average age for presentation is 40 to 60. There is a higher incidence in women. It is due to chronic ischemia of the median nerve at the wrist or in the carpal tunnel. This is an interesting article from New Zealand. They looked at 3,000 patients over a 10-year period that had isolated carpal tunnel releases. 2 to 1 female to male was noted, and the average age of the patients was 56. Symptoms were worse with age by decade, so those that were 70 were worse than those that were 50. There was no increased incidence of carpal carpal tunnel with a typing job. So how do we diagnose carpal tunnel? This is most easily made with a good history. Nocturnal symptoms are more diagnostic than a physical examination. Physical examination should be confirmatory. Electrodiagnostic tests, or EMGs, are not often needed for diagnosing routine carpal tunnel. Ultrasound is very helpful in identifying nerve pathology and is a very good confirmatory test for carpal tunnel syndrome. How is carpal tunnel syndrome treated? Well, carpal tunnel syndrome is treated upon symptoms and physical findings. Mild carpal tunnel syndrome has no motor involvement and thus no weakness. Recommendations for mild carpal tunnel syndrome are for night splinting, and this is generally successful. Moderate and severe carpal tunnel syndrome has increasing problems with motor involvement and nerve degeneration. It is most effectively treated with surgery. Surgery is performed by transecting the transverse carpal ligament. The only way to release the median nerve is to actually release the ligament. Outcomes are improved with done in moderate carpal tunnel syndrome versus severe carpal tunnel syndrome. We looked at office-based carpal tunnel releases versus surgery center or hospital-based carpal tunnel releases, and if there was any difference in those procedures here at the Andrews Institute. We had 388 total patients with mini open carpal tunnel releases. These were isolated procedures. No other procedures were done at the same time. 229 had a surgery done in a surgery center or a hospital. 147 were clinic-based. There was no difference in infection or outcomes based on location. There was a very large difference in cost to both the patient and the insurance company, as well as waste production. So in summary, carpal tunnel surgery is done as an outpatient. We use local anesthesia only. Most are done as an in-office procedure if they are done isolated. It's a small incision. Those with worse or more severe carpal tunnel syndrome can take longer to heal. Thanks.